Welcome to Understanding Assessments for Acquired Brain Injuries with Dr. Tracey Meyers.
Hello, my name is Dr. Tracey Meyers. I'm a licensed clinical psychologist and have been practicing in the field of neuropsychology for over 25 years. And today I'm going to be talking about different assessments that are key to helping understand and create treatment plans for people that have traumatic brain injuries. So I'd like to credit the folks at the Brain Injury Association of America and the Academy of Certified Brain Injury Specialists for some of the information. They have created comprehensive slides and educational and training materials to help educate people on brain injuries. So today we're going to talk about assessments as the cornerstone for TBI rehabilitation and treatment planning. We're going to talk about what kinds of assessments are the cornerstone. And these include neuropsychological assessments, occupational therapy, physical therapy, speech therapy, and a couple of additional ones that can really create a comprehensive approach to brain injury rehabilitation. So just a little overview of brain injuries. Over 5 million Americans experience disabilities due to brain injuries, and many folks that have sustained brain injuries require ongoing long-term care and supervision. And that can increase caregiver burden and cost of care, and also create the need for ongoing treatment. And so how do we do that? So we really need to start with assessments. So assessments of cognitive, physical, and communication impairments are really critical to developing comprehensive rehabilitation plans really over the course of a lifetime for an individual. Often people will get full evaluations when they're in an inpatient rehabilitation setting, but that person changes over time. And in 10 or 15 years, many of those rehabilitation skills and assessments are outdated and need to be updated. And so we want to think about assessments on a regular, ongoing basis as a way to really monitor a person's functioning and create new strategies sometimes as a person improves over time. So the clients that I'm going to be speaking about today, I'm going to be particularly focused on people that have come from an inpatient rehabilitation setting, nursing home, or psychiatric facility, and are now living in the community. And these programs, called home and community waiver-based programs, allow people to live in the community with supports like case management, homemakers, home health care aides, personal care, adult daycare, respite, habilitation, which really looks at helping a person habituate into their environment in a successful way, services for mental health, and other services like assistive technology. And these home and community-based services really rely on a thorough assessment to determine what does the person need. In the state of Connecticut, we have something called the Acquired Brain Injury Waiver Program. In a previous webinar, I talked more extensively about the creation of the waiver program. And these programs allow people to live in the community without needing hospitalization or institutionalization. And to develop these plans, the waiver program relies on thorough assessments, both in the beginning when the plan is getting developed, but also over time as a way to continually enhance and create new goals for the person. So to qualify for the ABI waiver program, assessments have to be completed. So that's an entry-level qualification. First of all, the assessment around a person's activity of daily living, or ADLs, have to be assessed. And also, if a person is eligible for this program, they require a neuropsychological evaluation to ensure that the person actually has cognitive challenges or changes due to their brain injury. So assessments are part of the qualification, part of the goal setting, and part of the ongoing monitoring of a program like the ABI waiver. You can see again some of the activities of daily living, ADLs, that have to be continually monitored to see how a person is doing. So these are things that we monitor for the ABI waiver program: health, memory, behavior, independent living skills, housing, right? So assessments can be based on how a person's doing emotionally, physically, medically, and more externally in terms of financially, vocationally, and economically. We want to look at things like mobility. How does a person get to places like transportation, social supports, religion and spiritual needs, psychological adjustment, even legal status? Does a person have a conservator? Do they need that? Substance use, etc. So assessments range from the smallest of, how many people does it take to help a person get dressed, to something much more global around psychological adjustment. So I'm going to start now with neuropsychological assessments for brain injuries. As you saw earlier, it's one of the key assessments to determine if someone's eligible for a program like the ABI waiver, because it helps to determine if the person had a brain injury, and if they had a brain injury, how the brain injury is impacting them. Okay, so who can do a neuropsychological evaluation? A neuropsychologist is a professional who specializes in the understanding of the brain and its abilities that are impacted by either an illness or an injury like a TBI. Neuropsychologists are either a licensed clinical psychologist or they have additional specialized training in neuropsychology. Other people that can help with the neuropsychological assessment include psychometricians or psychometrists. They're professionals that have been given specialty training, usually master's level, so that they can actually give some of the tests. But the psychologist or neuropsychologist actually does the interpretation and report writing. So if you see a neuropsychological evaluation, you know that it's done by a licensed clinical psychologist, likely with additional neuropsychological background or training. So what's the purpose of the assessment? I like to think about a neuropsychological evaluation as like the kind of functional part of an X-ray. So for example, if someone had an X-ray, you can see what's happening, the bones. Did someone break a bone? What's happening, with the structure of a person. But the neuropsychological evaluation is the function. It's showing what can the person actually do. So we can see behind the scenes in an X-ray or a CAT scan or an MRI, but that doesn't tell us what the person can actually do on a day-to-day basis. So an evaluation gives us this detailed description of a person's abilities, their strengths and their weaknesses in a variety of functioning. So first of all, it looks at, does the person have cognitive deficits? And if so, what are the patterns of those deficits? And it also includes psychiatric disorders too. So we're looking at both the cognitive and the emotional functioning of somebody. It also helps to determine the presence of a neurologically based disorder. Helps us understand if someone had a brain injury, a stroke, or other neurological issues that might be impacting their functioning. It can help understand how specific cognitive deficits contribute to problems in daily life, right? So if a person has problems with memory, how that might affect their ability to work, for example. And finally, it helps us establish a baseline. So often we'll do what we call serial neuropsychological testing, where we'll start with testing maybe 3 months after someone was injured, and then redo the testing in 6 months or a year or 2 years and see how the person is progressing or if they're getting worse over time. So that can be very helpful. And like I said in the beginning of this talk today, assessments over time are really important because it helps to determine what goals and what interventions a person may need at different junctures of their rehabilitation. It also assists, like I said, in treatment planning, whether someone even needs surgery. So sometimes if someone has a seizure disorder, for example, the neuropsychological evaluation can help assess what types of seizures they're having and potentially what kind of surgical intervention they may need. And it helps to make recommendations for accommodations in the community. And that's why the assessment purpose is really important when we're doing a program like the ABI waiver, where the evaluation gives sort of a roadmap of what the person may need in the community. And of course that can change over time, but it gives us the beginning plan. So what is the scope of an assessment? So essentially we're looking at the cognitive domains of a person, and we start with how the person was functioning before the injury. If a person, let's say, for example, graduated college and they were working as a professional, they have a brain injury and their intellectual capacity is now severely impaired. That helps us understand some of the challenges they may be facing, right? Versus someone, for example, who only has a small change in their overall functioning from how they are now to their pre-morbid, then that's going to impact what kind of services and what kind of adjustment they may need. So we want to look at pre-morbid functioning, and then attention concentration, sensory motor or psychomotor functioning, information processing speed, how quickly people process information, language and communication, visual, spatial, and constructional skills, learning and memory, intelligence, executive functions, and additional factors, psychological factors, mood, anxiety, personality, motivation. So you can see it's very broad, right? We're really looking at an overview of someone's capacity. And I like to think about it as a snapshot in time. It's not permanent. So a neuropsychological assessment changes. Some things we see tend to hold up over time if we tested someone 6 months or 9 months or 5 years later. But many of a person's functioning, even if they haven't had a brain injury, changes over time. So we want to be able to use the assessment for the current plan and recognize that we may need to adjust or change the plan over time. All right, so what are the assessment instruments? Essentially, we're using specialized tests that measure the behavioral performance of a brain functioning. And they're standardized. So we talk about neuropsychological assessments as standardized, meaning that we have a manual that we follow and we have to give the directions in a specific way so that every time we give it, it's the same. And that helps to recognize that it's consistent over time. So there's protocols for the administration of each assessment. And that helps us to know that it's more accurate, right? So that if we give the test the same way each time, that we're going to essentially be measuring something in an accurate, consistent manner. The second part of an assessment is that we're comparing the data. It's called normative data. We're comparing the data to someone who's the same, often age, education, socioeconomic status, race, gender, etc. So when we're comparing the person's data so that we have the most accurate data. Why is this important? Well, if I was comparing someone who was 17 to someone who was 86, that may not be an accurate norm group. And so we might over pathologize someone who's 87, whose memory is going to be very different than someone who's 17. So we want to find an age peer group, education matched peer group, so that when we're seeing if someone has a deficit, we're using the group that most matches them closely. So norms represent a range of typical performance in a population of healthy individuals around the same age, education, and background. So how do we do an assessment? So first we do a comprehensive record review, and that's really important. That helps us to look at the medical, prior assessments, brain imaging if it's available, detail around a person's behavioral and functional impairments. And when we're doing the record review, we don't always have all of this, we hope to, but often it can be school age records, so it can be as comprehensive as being able to get report cards from when a person was young, to hospital records around the injury. So sometimes it includes pre-injury and often post-injury data. Sometimes we don't have access to all of the records and we have to just make do with what we do have. But the more records we have, the more comprehensive and accurate the entire assessment will be. Then we do a clinical interview where we look at what the referring information is, really hear from the person what they feel is most significant, get a history of their development psychologically, school-wise, vocationally. We want to learn about their history from family, mental health, medical history, and substance use and current medication. So we're covering really the lifespan of a person and trying to get as much accurate information as we can about their life pre and post injury. And also how they're functioning now. How are they doing now, right? Are they able to work, or how are they doing in school, etc. Then we do the standardized testing, which again is based on using manualized procedures and using comparison data against norms. When we think about assessments, we have a couple of different approaches in neuropsychology. We can do what we call standardized testing with a fixed battery, and standardized testing with a flexible battery. A fixed battery involves a set of prescribed tests that we do over a series of hours or days that cover every function, right? From memory, attention, concentration, visual, spatial skills. We give the same battery of tests to everybody. It's called a fixed battery approach. And then a flexible battery is more tailored to the person. We're selecting the assessments based on how the person is functioning and what they want to know from the assessment as well. Most times, there's been really a movement toward this more flexible battery approach. It's more person-centered and holistic, and also involves a lot more ability to tailor it. And in terms of insurance and coverage, it can be more cost-effective. It can be shorter. So if someone is getting an evaluation and they just need it for driving, or they just need it for work, it might look very different than someone who's doing a very thorough battery for a court case, for example. So more and more neuropsychologists are using a flexible battery approach, although there are still many people that use a fixed battery, and those assessments are very well researched as well. So it's not like one is better than the other. And then finally, report and feedback. And this is often a lost kind of part of the neuropsychological assessment, but the feedback, giving people the information after they've gone through this comprehensive assessment. A typical neuropsychological evaluation could last 6 to 12 hours. And so it's really important to give the feedback. So we want to come up with a report based on the background, behavioral observations, factors related to the test validity. Did the person give good motivation? List all the tests, describe how the person did and interpret how they did, and then create a summary of a person's overall functioning, including strengths and weaknesses, diagnosis, potential implications, and recommendations. I often talk about this part. The report and the feedback are actually the most important part of the assessment process, because if someone goes through all that testing and never knows how they did, or the report is just kind of put away in a person's chart, it really isn't that helpful. So we want to make sure that the report and the feedback are provided to the individual and to the referral source and to the treatment team. Okay. So I really like to spend a lot of time on the report and feedback to ensure that all of that good data is actually being used effectively. And then we may do further assessment or additional assessments based on the results. So neuropsychological assessments describe cognitive functioning, and this is really the heart of an assessment across different cognitive domains. So these are different things that we might write about in a report that you might see, right? All of these different things. And all of these impact a person's daily routine, ability to work, ability to carry out skills. Fundamental cognitive processes that we find in a neuropsychological evaluation, like problem solving and abstract thought, really impact a person's overall life, right? A person's ability to have abstract reasoning can affect their motivation, their willingness to try new things, their ability to understand complex social situations. I could go on, but we want to understand both the fundamental cognitive processes that underlie the complex cognitive processes, and then we also want to understand the complex, so it's both. So we want to start with simple and then look at more of the complex interrelated cognitive abilities. So this example here, damage to the attention network can affect other areas of the brain as well. So that's why it's so complicated. Even though there's one particular area we might be assessing, it impacts other areas. And again, we're looking at different functions of the brain when we're doing testing. Like an MRI would tell you, oh, the person has a hematoma, a bleed, or some kind of bruising of the brain in the frontal lobes, but it doesn't tell you what that means functionally. A neuropsychological evaluation would say, well, deficits to the frontal lobe include the person has difficulty problem solving and learning new information. They have difficulty paying attention for more than 30 seconds without getting distracted. So we're taking what we see on an imaging or scan and we're making it come to life, so to speak. And these are the different areas of the brain and the different functions of the areas of the brain, and their overlap. And imagining, even if someone has an area of the brain that's not injured, if the connections with another part of the brain are injured, it can disrupt that functioning. All right, so we have these domains of cognitive functioning that we're looking at in the assessment: attention, categorization, memory, processing speed, executive functioning, and metacognition, awareness, right? I'm just going to briefly go through these. So attention, it's one of the most fundamental cognitive skills, right? Because if we can't pay attention, it's hard to then do any other task that relates to paying attention, and most tasks do. I like to think about attention like putting things into the computer. If you don't put anything on the computer into the computer, then there's nothing to remember and there's nothing to use. So it's our data input, right? It influences all other cognitive skills. And when people have had brain injuries, it's very common to have deficits in attention. And there are different kinds of attention. We call these subtypes, okay? We can start with focused, and I'm going to go through each of these: sustained, selective, alternating, and divided attention. So a person may have deficits in one or more of these areas, and that can affect higher level cognitive processing. So here's just some examples of focused attention. So focused attention is focusing on just one thing. So you hear a loud noise and you turn around and listen to where that noise came from. Sustained attention is completing a task over time. And this is an area that can be very challenging for someone with a brain injury: reading a book, watching a show, listening to a presentation. Selective attention, being able to ignore one thing while at the same time doing something else. Alternate attention, going back and forth between two things. And finally, divided attention, doing things at the same time. And research is a little divided about this, whether we truly have divided attention or we're really just rapidly alternating. And most neuropsychologists believe that we're actually rapidly alternating, and it could look like divided, but it's actually more of just fast back and forth. Okay, a couple of other things to go over. Categorization, the ability to categorize, really helps us to do our daily living skills, to know, oh, these are my winter clothes, right? My sweater, my coat, my hat, those are part of my winter clothes. That's a way of categorizing. And if you can't categorize, you might choose shorts and a hat, for example, because we're not able to categorize and organize effectively. Deficits can also impact acquiring new information, problem solving. The faster that we can process information, the easier it is to categorize. It's easier to problem solve, make decisions, right? So categorization skills are really important in terms of making higher level decisions and changing our decisions. So individuals with brain injuries tend to struggle with this. They may focus on a small or single attribute and have difficulty generalizing that to other things, right? So one situation, they can't quite generalize it to other situations. And that can be very time consuming, right? Because then each situation, they have to try to figure out what to do. Memory is a very complex topic. We could spend a whole day talking about memory, but I'm going to briefly go over a couple of key things to think about. So we can think about encoding, storage, or retrieval of information. When someone has memory deficits, that doesn't mean that all of their memory are impaired. It may be that they're having trouble storing information, or they're having trouble retrieving it, or that they're not paying attention long enough to encode the information. So encoding is getting the information in. Stabilizing or storage happens when the memory is in working memory and we start to organize it, and then we put it into long-term memory. And retrieval is like being able to pull the memory out when we need it. So essentially, things start as a sensory memory, right? And we hold that information very quickly, sometimes even out of our conscious awareness. And then it goes into short-term memory, which can last a few minutes or hours, right? And then long enough so we can do something with it, right? So we put it into working memory when we want to remember something. Maybe we write it down, we rehearse it. And then finally, we store it in long-term memory. And that becomes a permanent memory. So again, seeing how complicated our memory systems are, you can imagine that damage to the brain and different parts of the brain can impact the memory process at any of these steps. Our sensory input may be disrupted, or our ability to hold information in working memory, or our storage capacity. So short-term and working memory, these are really central in terms of being able to learn new information. Short-term, the color of a car that passes you, right? Something that just comes quickly. And we typically don't remember it because we don't need it. When we need information, then it goes into working memory and we try to figure it out long enough to do something with it. Calculating change, rehearsing a phone number. Storage and working memory are passive. Short-term and working memory are different from one another. Short-term is passive, working memory is active. The more active we are, the more likely we are to be able to use it later on. And then finally, long-term memory, permanent consolidation. We have both explicit and implicit memory. Explicit memory are ideas like reading a book, knowing, understanding words, right? Understanding concepts. Episodic memory is like our autobiography, remembering our own stories. Implicit memory are things like driving a car or remembering how to make a cup of coffee. We're not even trying to, we just know what to do, right? And again, damage to our memory could impact one or more of these areas. Typically, we see with clients with traumatic brain injury, we'll see disruptions in recent information. They may have good semantic and episodic memory, but they have more difficulty recalling more recent events, right? So it depends on where the brain injury damage is. Processing speed is very important because it allows a person to take information in, process it, and respond to it. And when information processing speed is impacted, a person may have trouble learning new information because the information took so long to process that they missed other things. And we see this in school with children who've had brain injuries. If they have slowed information processing, the teacher may have moved on and they're still trying to process the information they initially learned. So information processing is really important and can impact someone's cognitive functioning across many domains. And finally, executive functions. I've spoken about this in previous webinars about the role of executive functions in terms of behavior. And you can see how executive functions have a lot of complexity, reasoning, planning, judgment, initiation, abstract thinking. And we know certainly with people with brain injuries, it can really impact a person's ability to problem solve, execute, and maintain cognitive flexibility. So again, these are all the different things that executive functioning can support us with in our daily life. And people with brain injuries tend to have disruption in one or more, often many, areas of executive functions. And this is really the heart of some of the rehabilitation strategies with clients when they've been in the community, is helping them strengthen some of these executive functioning areas, right? For example, planning and organizing, or helping with learning how to do a new activity, rehearsals, helping a person delay impulse control. So that is often the heart of a person's rehabilitation plan, and therefore the assessment really helps to determine where do they need help with, what areas do they need the most support. All right, so these are some of the problems that can happen, and this is how we can approach teaching individuals. All right, a few more areas. Metacognition is this higher level regulation. Again, this can really create challenges for someone who has a brain injury because it can impact awareness of deficits, awareness of how these deficits affect a person's daily life, being able to set goals, and also being able to monitor one's own success. All right, so the final part of a neuropsychological assessment is personality testing. In a previous webinar, I talk about psychological and neurobehavioral functioning, and psychological assessments can help us screen for mental health conditions, both pre-existing and also following a brain injury. So personality testing is, again, giving us a snapshot in time of how a person is doing right now. So even if a person had depression in the past, when we do personality testing, we're really looking at how they're doing in the current present moment, and they can give us good insight into behavior, interpersonal skills, and also potential problem areas that we really need to concentrate on. Behavior and emotional changes following traumatic brain injury that we can pick up on with our personality testing: anger, depression, thinking difficulties, relationship difficulties, and psychiatric symptoms. So we're looking for these to see how many and where we might support the person, right? So all of these give us little mini roadmaps toward how we can help a person function more optimally. If someone has depression, that gives us a little roadmap of like, okay, we're going to need to do probably some psychotherapy and helping them with their mood regulation, maybe seeing a psychiatrist, right? So we want to ensure that we're creating plans that address what we find on the personality testing. All right, so how do we actually diagnose a brain injury from neuropsychological assessments? So the Diagnostic and Statistic Manual, DSM-5, created a diagnosis for brain injury called major and mild neurocognitive disorder due to TBI. And essentially, the neurocognitive disorders are basically a subdiagnosis. They're under the umbrella of other types of cognitive disorders. And they can be either major, because they create a significant change from a person's previous functioning, or they're more mild, so there's modest cognitive decline. Why the neuropsychological assessment is so valuable is that it helps actually to figure this out. Was it a major decline from previous levels of functioning or a modest decline? We can do that a little bit on our assessment of just how a person's doing in their daily life, but the testing gives us real baseline data to help us understand how much a person's brain injury impacts them. So neuropsychological testing helps to provide this information, whether the person had a neurocognitive disorder and whether it's major or mild. And so to meet the criteria, a person has to have had evidence of a TBI, and the evidence is either a loss of consciousness, post-traumatic amnesia, disorientation and confusion, neurological signs, imaging, and the changes in terms of cognitive functioning happened after the injury itself. There's another classification system called the ICD-10 that also helps to guide and code for insurance purposes a person's TBI symptoms. So that's another. And so both of these are used. The ICD-10 and the DSM are two different ways of classifying a brain injury. And they're similar, but you'll see slight differences. This is an example, and you can see the ICD-10 has very specific criteria. They get very granular, like where the lesion is it swelling? Is it a bruise? Is it a laceration, for example? And then they add in specific codes for the emotional state. So these are just different ways of recognizing and describing brain injuries. Here's a sample of a summary of a neuropsychological evaluation. Patient presents with a history of an ABI following a motor vehicle accident in 2007. She has demonstrated significant difficulties with cognitive and memory functioning since that time. The results of this evaluation note significant impairments in her ability to learn and retain new information, as well as in executive functioning areas. She also demonstrated a decrease in expressive language skills. Her current performance is clearly below her pre-accident baseline. She's also struggling with moderate levels of depression, including feelings of hopelessness and sadness, and disruptions in appetite, sleep, and libido. So that's a very concise summary talking about this is clearly someone who has had a test probably in 2007 and some repeated testing. She still has significant impairments and in fact has shown a decrease in her language skills and this recognition that she's performing way below where she was before her accident. And there are some complicated factors around mood. So that begins to create a picture of where some treatment interventions might come into play. And here's some sample recommendations. You can see how you can take the summary. This is a different recommendations, but you can take a summary and begin to create ideas. This person needs 24-hour services with the waiver. And they gave examples. They may need more support with activities of daily living, like transfers and dressing and eating. This person has an iPad, and the staff should help use the iPad for memory information, using a dry board and an erase board, regular calendar, things that he enjoys doing, right? And here's one about how to avoid confrontation. If he becomes agitated, a way to find some agree to disagree strategies, ways to include the family, and then a recommendation for testing. So at the end of the day, it's really important to have good recommendations. So there is a roadmap to take all of that data and use it effectively. Okay, so it started with neuropsychological evaluations. They tend to be the broadest. And now we're going to go into a couple of other really important assessments. Occupational therapy. So occupational therapy is really important in terms of looking at living skills. So typically an occupational therapist works with a PT, a physical therapist, and a neuropsychologist to look at how to help a person with practical skills. So they're really often focusing on a person's ability to work on real life skills like cooking and dressing and going to the bank, shopping. And so they're looking at a person's skills across many different domains. So when someone's doing an occupational therapist evaluation, they're looking at, is PT involved, because they don't want to duplicate. Sometimes there can be a duplication in some of the services. They want to observe, and then they're looking at all of these different domains: range of motion, strength, endurance. I'll just keep showing you a few more. Transfers, gait, cognition. And again, there's some overlap with some other evaluations that I'm going to share with you. So we want to be very specific of who is doing what when we're creating a team of professionals. Evaluation tools. So you may come across the Coleman evaluation of living skills or the Allen cognitive level. And this helps to determine how much assistance does a person need. So for example, when creating the ABI waiver, oftentimes an occupation evaluation can give a sense of how much supervision and what kind of safety mechanisms need to be put in place to make sure that the person can live successfully in the community. So here's a sample summary from the Allen. The person needs 24-hour supervision, removing dangerous objects. They may spend a daily allowance, and they could do a familiar bus route, but they need help with medication. So it's just giving this overall picture of where the interventions and caregivers might support the client. And just like the neuropsychological evaluation, it's a snapshot. If someone has been very successful in a setting, it may be helpful to repeat the Allen cognitive level. Maybe they've had 24-hour supervision for 3 months, and then they get assessed again and their performance improves and they only need 4 hours of supervision. So it's important to take the information and then reassess. Take the information, reassess. Physical therapy. So physical therapists are movement experts. They're really looking at helping a person restore fitness and wellness after a brain injury. They also help with hands-on. So they'll do some hands-on manipulation, patient education, and creating exercise programs. So these are some things that a physical therapist evaluates. You'll see some overlap with the OT eval, like around gait and balance. So it's important, again, for PT and OT to kind of figure out who's doing what. Looking at strength and tone, a lot of adaptive equipment PT evaluations will start to assess. Does a person need a wheelchair, a walker? How many people does the person need to transfer safely? So an evaluation looks at, how a person could be safe in their community where they're going into. So PT evaluation may be helpful in terms of how much accessibility a home needs to have. Does it need to have wide doors? Does it need to have a walk-in shower? PTs will do different kinds of assessments. These are typical standardized testing, and some of these are more inpatient if someone's in an inpatient hospital setting or even in a coma. And then when they become much more functional in the community after they've recovered, right? They're going to be looking at different skills. One of the common ones, the Mayo-Portland Adaptivity Inventory, looking at physical, cognitive, and emotion. And you'll see again overlap between the Mayo-Portland and some of the neuropsych and OT evaluations. Speech and language evaluation. So the purpose of a comprehensive evaluation with brain injury and speech really is to look at speech itself, language skills, communication, swallowing, and hearing, right? So that's the purpose of an evaluation. So a speech evaluation is going to first look at non-speech things like a person's ability to actually make the movements to speak, their breathing, their oral motor skills, how they can move and coordinate speech, the tone and steadiness and movements of speech. And then how they actually can vocalize speech, how loud they are they able to read or speak for a period of time? Do they have complex motor planning issues? Is their speech intelligible? Can you understand the person? And is it comprehensible? What they're saying, do they stay on topic? Does it match with what the context is? And then we look at language, right? Does the person have the ability to communicate and understand language? And is it practical what they're saying? And how much of their cognitive challenges are impacting their communication? For example, if someone has attentional issues, they may start to say something and then they get distracted, right? So cognitive functioning also impacts speech. So a speech evaluation may include a swallowing assessment if someone has aspiration or choking risk, and also the identification of coping skills and communication skills like an augmentative and alternate communication device, or AAC. So like a Dynavox or some kind of letter spelling computer program can help. So many clients with brain injuries utilize these to communicate their needs. They might press a button or type in if they have oral motor issues and can't communicate, or they have aphasia. And this can really improve quality of life to have a way to communicate. And of course, speech and language work with other disciplines to find what modalities are going to work most effectively. So if someone has motor issues, maybe they have trouble pointing their finger, or they have tremors, an OT might help the speech therapist determine what kind of device is most effective. Physical medicine and rehabilitation. So physical medicine and rehabilitation physicians are called physiatrists, and they specialize in physical medicine. They look at the whole person as kind of a holistic approach. Typically, physiatrists work with PT, OT, speech, and neuropsychologists to help improve the balance, vision, independent functioning, cognition, right? So again, if we think about each of these disciplines have lots of overlap and can support one another, physiatrists sort of looking at each of these and helping the different key rehabilitation professionals work together like a good orchestra. Physical medicine physicians also use things like Botox and EMGs to help with things like tone, muscle tone, gait issues, and also can really help support the team as the person is progressing from inpatient to outpatient to community. So many physiatrists kind of work with the team along a person's lifespan as they change, improve, and need additional supports and services. A PT can also order or prescribe physical therapy, occupational therapy, and sort of know when to call in the different professionals. So again, that idea of the coordination like a conductor of the orchestra is a good analogy for a physiatrist. and vocational assessment. So I wanted to spend a little bit of time talking about a vocational assessment because they really put together the whole kind of plan. So a vocational assessment takes an occupational evaluation, a physical therapy evaluation, a neuropsych eval, a physiatry eval, speech and language, and helps a person who wants to go back to work really look at what is the person capable of. And so typically an initial vocational assessment takes all of those early evaluations, puts them together, and works with the client to think about what the person can do to create a meaningful vocational life. And so really helping the client to explore what their goals are, what their abilities and skills are, and matching them with a potential career. And why is this so important? Why is vocational kind of the end result, or why am I ending here? So vocational assessments are really important for quality of life, giving people meaning and purpose, socialization, joy, a sense of accomplishment. So many clients that are on the brain injury waiver often talk about wanting to work. And we might be starting first with volunteering, for example, and then moving into supportive employment with a job coach, and then eventually competitive employment. I have a client who was in an inpatient hospital after a brain injury. He sustained a brain injury from a fall. And as he went into the community, he spent the first 2 years of his program working on walking, working on relearning tasks like cooking. He had a lot of cognitive skills training using his iPhone, and he worked with a speech pathologist. So he did all of those initial assessments. We worked on coping skills, memory issues, ways to emotionally regulate. And then he was ready. He really wanted to just start to think about working again. So he had a vocational assessment where they put together all of these different areas of strengths and limitations and began exploring what types of jobs might work well for him. He started by doing some volunteer work. He answered phones, he did mailers, he helped other clients in a facility. So he did lots of different volunteering, worked in a nursing home. He wanted to just start to learn how to work with people again, and then progressed slowly and gradually to taking on new job tasks, including working in a drugstore, starting to put things on the shelves, eventually progressing to being able to work as a cashier. And each step of the way, it required this multidisciplinary approach headed up by a vocational counselor to be able to assess how he's doing based on his current level of functioning. So you can see with all of these different assessments, they each contribute to a person's quality of life. One assessment alone gives a snapshot of one area. And that's why we want to make sure that when we're working with someone, that we're doing a comprehensive overall evaluation and put together the neuropsych, the OT, the PT, the speech, physiatry, and vocational assessments, so we can really determine how the person is doing, continue to monitor and create new goals, which, like in my clients' cases I'm talking about here, created a sense of meaning and purpose and progress. There are additional assessments I didn't include here, like driving evaluations, cooking evaluations, specific gait evaluations that are offshoots of many of the more global evaluations I share today. And each of those have, really important roles depending on an individual client's needs. But overall, the assessments I reviewed today are typical and really important when we're creating ongoing plans for clients living in the community. So I thank you for participating in this assessment webinar today and look forward to seeing you again. Thanks.